Clinical Systems Intelligence Training, Module 4, Patient Pathway, Secondary to Primary Care. What will you learn about in this module? I work in secondary care, and after completing this module I understood how the transfer of care between secondary care and primary care works, including medication referrals. As our product is only prescribed 6 monthly, we were able to implement a tactic which meant clinicians in primary care could be automatically alerted on their systems when the next prescription was due. So Module 4, Managing the Patient Pathway between Secondary and Primary Care, we're going to look at e-referral, discharge summaries and secondary care clinical audit. So our key objectives for this module are that you understand how referral data is transferred between primary and secondary care, and that you understand how data flows between secondary and primary care and how it's captured. Okay, so let's start with the NHS e-referral service. So that's going from primary to secondary care. So it's an electronic booking service which provides options to select the first hospital or clinic appointments for patients. So patients may select their initial hospital or clinic appointment either in the GP surgery, so often the patient is sent off to reception or to one of the secretaries to log on to the system and choose their preferred clinic and place of referral, or they can do it later on at home or on the phone or online. The patient demographic service provides the patient details, and the message is via the N3 secure network, which is used to link the patient, the GP practice and the secondary care system. So referrals are fully integrated within the GP clinical system, and what often happens is template letters are given to the practices either directly from the hospital department or through the CCG, and they collect all the relevant information that's already in the medical record, and that's used to inform the secondary care team, and that also logs as a coded entry in the patient record so it can be searched on at a later date. So the NHS referral service from secondary to primary care is all around the discharge and the exchange of care from one place to another. So patients are typically discharged between Mondays and Fridays, and thousands of discharges are completed daily in England, and obviously across the devolved nations as well, but most of the information we have is for England. Discharge summaries and outpatient letters to the primary care provider are usually sent electronically. They're still occasionally handwritten, but not often. The discharge notification informs the GP of the reason for admission, a summary of the treatment, instructions for further treatment and follow-up, and any changes or any new medications added. So changes in medication supplied by the hospital with instructions to the GP to update their electronic records for subsequent repeat prescribing, and delays in discharge notification or updating the GP record can result in omissions. So it's very important that this information is dealt with in a timely manner at the practice. So obviously there are risks to patient safety which can occur on discharge from hospital when vital information is not transferred quickly to GPs and community-based services. Until recently there have been no common standards for the way in which information is recorded in discharge summaries, which means it often needs to be re-entered onto the GP systems, which obviously risks errors occurring. So it was decided there was an urgent need to improve patient safety and continuity of care by developing some standards for discharge summaries. So what possible errors could occur? So one of the most obvious ones is a transcription error. So when you're dealing with data and it's not being put into the system electronically, so this could happen at any transfer of care point. So at the admission stage, at the discharge stage, and when updating the GP system. And obviously one error made at the transfer of care could result in numerous repeated errors on either way. So if there's errors in the admission data, that's going to affect the patient while they're in hospital. If there's errors in the discharge information, that's going to be fed back through to the primary care system. and if there are errors when the transcription is actually happening to update the GP system. So if that's happening manually, then obviously any changes can have a big impact. So if you imagine all the patient's medical record data is coded, and if those codes aren't put in or the wrong code is put in, then that could affect the patient moving forward. So they might not appear in a search, they might not get an alert that they need to alert the doctor that something needs to be done. So it's very important that this information is accurate. There could also be inadvertent continuation, so drugs that are intended to be stopped. So the consultant would say, okay, I'm going to change you from this to that, and the information isn't updated correctly at the GP's end. Some examples there. Or in the same way, inadvertent discontinuation, so new medicines prescribed at the hospital aren't continued. Obviously that could lead to treatment failure and patient harm and readmission because the problem that was dealt with hasn't been continued. You've also got therapeutic duplication, so as I say, the hospital stops one type of drug and replaces it with a different drug for the same indication. The example given there is antihypertensive treatment, so one drug is intended to be stopped but isn't, and the new drug is started. So that could lead to obviously catastrophic results there. And then drug toxicity. Following on from the therapeutic duplication, multiple treatment can result in toxicity. So examples there, and then leading to lack of monitoring and follow-up. Insufficient monitoring with warfarin could result in blood clot formation or catastrophic bleeding. So you can see there's some big problems here that could happen if these discharge summaries aren't dealt with accurately. So the NHS standard contract requirements for England, we've now got a fully digital NHS requiring detailed standards for how discharge summaries and clinic letters are to be structured and sent to GPs, and this includes acute inpatient discharges, emergency care discharges, day case care and mental health discharges and outpatient letters. So from the 1st of October 2018, both discharge summaries and outpatient clinic letters must be a structured message, capable of carrying both human readable narrative and coded information, so it can go straight into the clinical system. They must use consistent headings, the Professional Record Standards body have given us a set of headings that they must use, and they must be sent by direct automatic transfer to the GP practice electronic patient record through a suitable secure interface, rather than being sent by post, fax or email. So the Professional Record Standards body, it's a national body, so they've put together these standards. So the e-discharge summary, the standard ensures that all relevant information is shared with GPs in order to improve the quality and consistency of care, and that includes diagnoses, medications, procedures and allergies. And the key requirement on the provider, so following inpatient, day case or A&E attendance, to issue a discharge summary to the patient's GP within 24 hours. And then for outpatient letters, so outpatient letters are the main method of contact and communication between hospitals and GPs, and often it's the only record of the consultation held by the outpatient department and the hospital. The standards will improve continuity of care by helping clinicians to firstly communicate relevant information more quickly, and also to reduce transcription errors by enabling reuse of key data in the GP system, so rather than having to manually enter the data. So the key requirements on the provider are that following outpatient attendance, to issue a clinic letter to the patient's GP within 7 calendar days. So this is sort of setting out the standards that they need to adhere to from the secondary care to primary care end of things. Okay, please pause the presentation here and answer questions 1 and 2 for this module in your workbook. Start again when you're ready. Okay, so secondary care clinical audit, let's have a look at this. So the NHS has some of the best data systems in the world, and NHS Digital provides data collection for a raft of data sets for specific areas of health and care across England. National audits include cardiac rehabilitation, bowel cancer audit, diabetes prevention, foot care. All sorts of things are covered by national audits that come from the hospital data. Healthcare Quality Improvement Partnership, HQIP, was established in April 2008 to promote quality in healthcare. It's an independent organisation led by the Academy of Royal Colleges, the Royal College of Nursing and National Voices. It includes data for England, Wales and Northern Ireland. It will vary according to audit. Some audits are England only, some cover the different devolved nations. And Healthcare Improvement Scotland have their own programme, and they have a programme that supports health and social care services to improve. So an example of a national audit is the Sentinel Stroke National Audit Programme, the SNAP audit. So this assesses the quality of multidisciplinary inpatient stroke health services in England, Wales and Northern Ireland. And you can see there the data is published and it's available, and you can access it using the link here. You can drill down into regional and local areas and look at performance tables, and you can see the kind of level of data that is available from secondary care. So nationally the picture is quite good, but on a local basis secondary care audit has always been more problematic. So providing local level clinical audit has traditionally been more difficult and is often a manual process due to the lack of interoperability of systems used in secondary care settings. So you'll find that different hospitals have different systems, and not only that, different departments within different hospitals will have different systems. So they've all been developed separately. So what's often happened in doing secondary care audit is that data is collected manually, so from paper notes or from the hospital computer systems, and it has to be transferred into another system for analysis and report writing. So it's quite difficult to join it all together from a local place. So I've got a couple of case studies to go through with you here, looking at some of these issues. So this was around referrals from primary to secondary care. This is some work we did a few years ago. So the situation was that a new e-referral service had been launched and was available to all GPs across 2 CCGs. And what they'd done, they created a central hub. It was a physical hub, so the teams were physically there, and they were responsible for assessment of all referrals from these 2 CCGs. But what was happening were delays were happening, being experienced as incomplete referral information was being sent by GP practices. So rather than the referral being sent on to the hospital, the correct department, they were being sent back to the GPs to say we need more information, and that was causing delays. So the solution we came up with, so there was a range of template letters, so each speciality within the hospitals, within the secondary care settings, had agreed what letters they wanted, what information they needed, and these were put together by the CCG and were distributed to all GPs. And the letters were set up to be auto-populated with patient data from the clinical system and also logged in the patient record and coded. So we got involved with doing some training. So we did several sessions training for medical secretaries to support them using the new system, and then including onward referral to the hub. So we showed them how to mail merge the letters, or first of all how to put the letters on their clinical system, how to mail merge them to gather all the correct information, and then how to enter them into the new system to refer them onto the hub. So the results were, after we'd done that training, decrease in numbers of referrals being returned to the GP for additional information to be added, decrease in time from referral by GP to appointment made for the patient, and an increase in cross-team communication. So in-depth discussions involving complex patient care were happening in real time within that central hub. So rather than going backwards and forwards to the GP and then to a different person, they were all able to talk to each other about that same patient care. And there's a full case study available on the NHS Worcestershire CCG website, and the link is here if you want to look at it. So another case study here, which is to do with referral information, was around dose titration following discharge from secondary care. So the situation here was that a secondary care initiated product required titration to optimal dosing in primary care, and the data coming back showed that 60% of appropriate patients weren't having their medication titrated, and so patients were remaining on suboptimal dose and maybe even stopping taking the therapy because they didn't think it was working. So the solution we came up with was an e-portal which held resources for both secondary care and primary care. So the secondary care resources, we provided access to a template e-discharge summary and a template letter to signpost practices to the e-portal. So the template letter collected all the relevant information or prompted the secondary care clinician to put in the correct information about when the therapy should be titrated. And then when that arrived in the primary care end, the e-portal, which they were signposted to on the patient's discharge letter, gave them guides on how to record the data correctly and complete the actions from secondary care, and actually do a post-dated script including the titration. So it was all added at the time. So as soon as the letter came in from the secondary care, the practice staff would add the data on, add the new post-dated titrated script, so it was all ready to go at the right time. And the results of that were that increased numbers of patients were titrated to optimal dose in the areas where the initiative was used. So this was all hosted centrally, so it was available to all different areas. So it was say not only available for secondary care, but it helped primary care as well. This is another project around secondary care audit. So the situation here is that tertiary care centres wanted to understand local and national pictures for time from referral to initial assessment, to diagnosis, to treatment plan, to first dose of treatment. So the only option was for data collection to be done using a very time-consuming paper-based system. So the solution was a bespoke data collection and reporting system which we developed, provided end user training, and we offer ongoing support and management. So the results are instantaneous reporting, so from the data being entered into the system which is available in the tertiary care centre, then reports can be provided and centres are easily able to benchmark their performance against each other. I'll give you a bit more information about that. This is how it works. So you've got an overview of the process flow here. So inputted data to reporting. So the nurses within the tertiary care centre complete the questionnaires on the secure e-portal. So that can be done either with the patient in front of them or from the patient's notes. If they're doing a notes review and they have incomplete information, they can telephone the patient and get that information. So no patient identifiable data is either input or stored within this system. So it's all anonymous. Anonymous questionnaire data is stored and processed by the secure e-portal, and then that data, as soon as it's entered, is available to display. So it's collated and displayed on the secure e-portal. Different levels of access are granted, so they can either see information just for their own centre or for across a group of centres or nationally. And so once they've seen the data on the portal, they can also create an output report. So if they want to, they can just click a button and they would get a PDF report. So they can get them by geography and a selection of individual centres, times between referrals, assessments and treatment, etc. So they get all the data they need. So notes going through the portal rather than having to be taken from another system and analysed separately. Okay, so thank you for completing Module 4, Managing the Patient Pathway between Secondary and Primary Care. Please make use of your workbook to record your notes and answers, as these will be used during the live webinar.